Medurstand-Understanding Medicine.
Professor Aziz Rehman from Medurstand-Understanding Medicine. Today we are going to examine the role of this newest SGLT2 inhibitor in the management of type 2 diabetes. You all know that the prevalence of diabetes is increasing worldwide, and the numbers are staggering. And if you project to 2045, 783 million people are going to be diabetic, and we are still not able to cope with the existing number. So I think the gap between those who need treatment and those who are actually getting treatment and are at goal is going to increase further. So we need more and more effective medication to fill that gap. In Pakistan, the statistics are very gloomy. Now, according to the survey, this is IDF Diabetes Atlas, the prevalence of diabetes, the percentage of adult people living with diabetes, Pakistan is number one. Very, very unfortunate fact. But if we consider the total number of people, then we are at number three, because China and India, being bigger countries, they have more number of people, but we have more percentage of people with diabetes. So that's very, very gloomy picture. Why is that? Partly because of genetic factors. We all know that we have this insulin resistance, inherent built-in insulin resistance. Our metabolism is actually designed to live in a semi-starvation state, but now we have too much food to eat and very little work to do because life has become very, very sedentary. But acquired factors, that's overeating and sedentary lifestyle, is equally contributing. It is actually enhancing the effect of genes. So due to that, I think more and more people are becoming diabetic. And I must admit one thing also, because of the more and easy access to the lab, more and more people are actually getting diagnosis earlier on also. So diabetes remains a challenge despite so many treatment options available. We have so many oral agents of different classes. I will not go into the details. And then we have many injectables also, insulins and GLP receptor agonists. And despite that, diabetes remains a challenge due to many reasons. And latest addition to our armamentarium are SGLT2 inhibitors, and out of these SGLT2 inhibitors, Ertugliflozin is the latest. These SGLT2 inhibitors, because of their unique benefits through good glycemic control and the benefits beyond, and they have already taken almost the first position in many guidelines, or at least in some of the guidelines. So this is why this group of medicines has become particularly important. Very briefly, we have list of these SGLT2 inhibitors: dapagliflozin, canagliflozin, empagliflozin, ertugliflozin, and sotagliflozin is actually SGLT2 as well as SGLT1 inhibitors, but these are highly selective SGLT2 inhibitors. SGLT2 is situated in our tubules of the kidney, nephrons, and the primary objective of SGLT2 is to reclaim, to reabsorb filtered glucose. And that was actually very, very important for our survival. Otherwise, after eating within few hours, we would become hypoglycemic because all the glucose will be filtered into the urine. Some glucose is also reabsorbed by SGLT1, which are distally situated, but mostly it is SGLT2. SGLT1 is mainly situated in the intestine, so those sotagliflozin will not only prevent glucose reabsorption in the renal tubules, it will also prevent absorption in the gut, so that will be more effective. But our focus would be only on the SGLT2 inhibitors. So their action is unique. The primary action is glycosuria. I think technically speaking, SGLT2 inhibitors lowers your renal threshold, the level at which kidneys allow glucose to filter down in the urine. So uh, preventing, by promoting glycosuria, by preventing reabsorption, and by promoting glycosuria, these SGLT2 inhibitors, they produce a state of normoglycemia or near normoglycemia. They do not cause hypoglycemia because once new renal threshold is reached, there will be no further lowering of glucose. Of course, if you're giving SGLT2 inhibitors with sulfonylurea with insulin, then after adding SGLT2 inhibitors, you might notice hypoglycemia, but that hypoglycemia is actually caused by the other therapy. So through this mechanism, we will get the glycemia related benefits. We all know diabetes causes many complications. Diabetes causes complication through various mechanisms, and many of them, particularly the microvascular complication, are through this hyperglycemia related mechanism. So by achieving normoglycemia, we can expect to achieve these glycemia related benefit through SGLT2 inhibitors. But actually SGLT2 inhibitors, they have additional actions, natriuresis. It promotes the sodium excretion also equivalent to mole by mole, equivalent to the glucose. So that will actually cause some contraction of extracellular compartment, some lowering of blood pressure, some lowering of afterload, some lowering of preload. So that might extend some cardiac and some renal benefits. And then there are many pleiotropic effects. These effects are actually, there's a long list. These SGLT2 inhibitors may have effect on myocyte metabolism and endothelial function, oxygen, inflammation. So all these mechanisms, they add to the effects, and then we have additional benefits. So that is why SGLT2 inhibitors have become very, very popular. So ertugliflozin is today's discussion focus. Now, these are SGLT2 inhibitors already available, and they have a certain selectivity. And ertugliflozin is highly selective, something like 2,234, fold more selective for SGLT2 as compared to SGLT1. Empagliflozin is actually even more, that is like 2,500. So selectivity means that it would not have any effect on the GIT and would not cause any GI upset and would not have any effects on other areas, because I believe SGLT receptors are present in the rest of the body also. So these are 4 points. Whenever guidelines are developed and guidelines, we follow guidelines, these are the 4 things which are kept in focus. The ability of any drug of lowering HbA1c, because that is the primary goal of diabetes treatment. And then those which are less likely to cause hypoglycemia are favored, because hypoglycemia becomes a hurdle in achieving ideal goal and also becomes a major complication for the patient. Then weight reduction. Most type 2 diabetic patients are already overweight, and we don't want them to gain further. Many drugs, insulin, pioglitazone, sulfonylureas, they can actually promote weight gain. So if there is any drug which can lower glucose without causing hypoglycemia and without causing weight gain or actually promoting weight loss, is definitely more welcome. Then end organ protection. This is very, very relevant because 80%, 75% to 80% diabetes complication and morbidity and mortality, particularly mortality, is related to cardiovascular complication. So if there is any drug which does not address this cardiovascular health, is not actually doing its job. So let's now examine ertugliflozin and its ability to lower A1C. So most of these studies about ertugliflozin are based on this series of trials called VERTIS, Evaluation of Ertugliflozin Efficacy and Safety. And then these studies are extended, they are monotherapies, then they are with different oral agents with insulin, and particularly the CV component which studies, which examines its cardiovascular safety. I'm very briefly going through all of them. Time will not allow me to go into the details, but very briefly I'll touch upon all of them. So this is Virtus Mono, study design and methodology. Objective was trial of ertugliflozin monotherapy added to diet and exercise. So relatively newly diagnosed cases who were put on diet and exercise, but they were not on goal, then they were put on ertugliflozin versus placebo. It consisted of two phases, 26 weeks and plus 26 weeks. Now this is the protocol placebo. After randomization, one third were put on placebo and another third was put on ertugliflozin 5 milligram and another third was put on ertugliflozin 15 milligram. And those who could not achieve, amongst the placebo, those who could not achieve their goals, they were given metformin, and the study was continued up to 52 weeks. And the results were quite good, and in placebo there was very little reduction in A1C, but with 5 milligram there was substantial 0.7% reduction in A1C, and with 15 milligram there was more, 0.8. Now one thing I have noted, and I have looked to share with you also, that the difference between the starting dose and the maximum dose is not much. That means with all SGLT2 inhibitors, we can achieve a reasonably good effect with even the starting dose. But of course, in some, we will have to give the full dose to achieve further benefits. This graph is the same with placebo, no significant difference, but with 5 milligram, a certain degree of A1C reduction, and with 15 milligram, more A1C reduction. So that confirms that ertugliflozin as monotherapy is effective in lowering HbA1c. Now this is other studies. This is mono. This is with metformin. This is VERTIS and with sulfonylureas. Particularly glimepiride was used in this study. The ertugliflozin with sitagliptin and other drugs. Now, and triple also, ertugliflozin plus sitagliptin. So I think one thing I like to mention here is, and this graph also shows, in all studies, 5 milligram or 15 milligram had additional A1C reduction. So compared to their existing treatment, adding placebo versus adding 5 milligram or 15 milligram ertugliflozin showed further A1C reduction. This happened in all groups. Now, it is extremely important to mention here that this SGLT2 inhibitors, they have unique mechanism of action. Their mechanism of action is not shared by any other known glucose lowering therapy. So whatever the stage of diabetes may be, whether it is early, whether it is advanced disease, unless patient has got CKD, you can expect the same glucose lowering effect in all patients and all population, because the mechanism of action is based on glomerular reabsorption of glucose that remains intact. Whereas those drugs which work through beta cells, they tend to lose their effect with time and as the disease advances. The typical example is sulfonylureas. So in these studies, in whatever combination ertugliflozin was used, whether as mono or added to other drugs, it did show significant HbA1c lowering, more with 15 as compared to 5. Average 0.1 to 1.2%. Then ertugliflozin was compared with glimepiride. Glimepiride is generally considered to be a very effective medicine, very potent medicines. And you can see that ertugliflozin 15 milligram versus glimepiride approximately 3 milligram. Like in real world, glimepiride was started with a low dose 1 milligram and then gradually increased to the desired level. So average dose was 3 milligram. With the 3 milligram, 15 milligram of ertugliflozin, there was slightly more reduction of A1C with ertugliflozin. So at least it may not be statistically significant, but at least you can expect ertugliflozin to give you the same degree of A1C reduction as you can expect from a glimepiride, which is considered to be a relatively potent drug. So with advantages of SGLT2 inhibitors, you can expect the same degree of A1C lowering with the ertugliflozin. And when we compare the fasting plasma glucose, ertugliflozin was actually superior to glimepiride. Very interesting. So now I'm going to present a very briefly ertugliflozin versus other SGLT2 inhibitors. Now, these are not actually head-to-head trial. This is not that dapagliflozin, empagliflozin, or ertugliflozin were studied in one study, but they actually use a different model. This model-based meta-analysis of different these SGLT2 inhibitors were studied differently, and then their results were compared. And then they came up with this conclusion. I'm not an expert on stat, but they came up with this conclusion that ertugliflozin 15 milligram, which is the maximum dose of this drug, compared with dapagliflozin 10 milligram, which is the maximum dose of that drug. So there was some further reduction in A1C. So at least as potent as DAPA10, but slightly more than dapagliflozin maximum dose. Similarly, when we compare ertugliflozin 15 milligram with empagliflozin 25 milligram, maximum versus maximum dose, again more A1C reduction. So with ertugliflozin, you can expect the same benefit which we expect from dapagliflozin and empagliflozin with more A1C reduction. And you know, many studies have shown that many of the complications, particularly microvascular complication, they are related to A1C. And A1C, 1% reduction, A1C could mean 30 to 40% reduction in retinopathy and nephropathy. So that is actually any further A1C reduction without hypoglycemia, without vein gain is actually very welcome development. So we're done with this A1C reduction. Now let's talk about the chances of hypoglycemia. This slide actually appeared, and I think, yeah, this is one. And I would like to, this is the data from that study where ertugliflozin was compared with sulfonylureas. HbA1c reduction was equal or slightly better with ertugliflozin, but particular advantage was lesser hypoglycemia. Even theoretically, I think you can believe that ertugliflozin or any other SGLT2 inhibitor would not cause hypoglycemia because it only lowers down the renal threshold. It can't bring it to the zero. It can't bring it to even 67, the dosage used. So once that new threshold is achieved, then there will be no further lowering unless patient is taking concomitant insulin or secretagogues. SGLT2 inhibitors, in this case ertugliflozin, is extremely unlikely to cause significant hypoglycemia, particularly the type 2, the stage 2 hypoglycemia where third-party intervention is needed. Now let's take the third issue, the weight reduction and the effect on weight with ertugliflozin. And those studies which I have presented earlier, in earlier slide I talked about A1C, but here there is a comparison of weight with placebo, no weight or weight gain, but with ertugliflozin with 5 milligram significant weight reduction, and with 15 milligram even more weight reduction. So up to 3 kg, up to 3 kg average weight reduction in 1 year. This trend of weight reduction might not continue, but if patient is also working, if the patient is also doing his part, controlling diet and doing exercise, then ertugliflozin can really help you to reduce weight. That would also translate into many benefits beyond glycemic control. So weight reduction was sustained. Very interestingly, this is placebo, and you can see that the weight reduction was maintained up till 4-5 years. So very durable effect. As long as patient is taking medicine, not only weight reduction continues gradually, but it is maintained. So it is not going further. There, in many medicines, there may be initial response and then there may be relapse, but SGLT2 inhibitors, in this case ertugliflozin, maintains the weight at a lower level throughout the study of 4-5 years. Now let's take the last component, end organ protection. Let's see how ertugliflozin fare on this parameter. End organ protection, and this is the cardiovascular outcomes trial following ertugliflozin treatment in patients with type 2 diabetes, mellitus, and atherosclerotic cardiovascular disease. Now, this is a very robust study published in New England Journal of Medicine, and we all respect this journal for its credibility, and this was published there. Compared to many other SGLT2 inhibitors like EMPA-REG about empagliflozin, which had already shown cardiovascular benefits, Canvas has also proven cardiovascular safe. Declare about dapagliflozin, this is also proven that these drugs are not only safe, but they actually extend benefit, particularly in heart failure. And this Vertis CV is about ertugliflozin. This was, of course, the last one because ertugliflozin was the last one to come into the field, and that was started in 2016 and completed in 2019. And the last patient visit was shown here. And so the data is now available. Like many other studies, it was multi-center studies, 531 studies and 34 countries representing all cultures and all races, all ethnicities. And it showed the typical pattern, multi-center, randomized, double-blind, placebo-controlled, event-driven trial, randomization 1:1:1, placebo, 5 milligram, and ertugliflozin. And the primary endpoint was the typical CVOT trial endpoint, composite out of the outcome of MACE, 3-point MACE, cardiovascular death, or non-fatal myocardial infarction, or non-fatal stroke. Whichever comes first would be counted. So I think this is the main criteria, primary, but there are many secondary criteria. If you're interested to go through these, you can hold the video here and go through, but to save time, I'm just going to skip this part. In placebo, there were 2,747 patients, 5 milligram, again similar number, and 15 milligram, similar number. So clinical visits, randomization, and the 52 weeks, these are the visits, they were analyzed, and then they were further extended by another 24 weeks, and this is the follow-up study. And of course, these patients were given there because they had atherosclerotic cardiovascular disease. They were given their standard of treatment. They were treated by aspirin, statin, angiotensin converting enzyme inhibitors, or whatever drug they needed. And they were actually continued on their existing anti-diabetic medication also. And over and above, placebo versus ertugliflozin 5 milligram or 15 milligram was given, and the effect on cardiovascular outcome was observed. So these are the results. Now, out of 8,246 patients with type 2 diabetes and atherosclerotic cardiovascular disease, now all of them, unlike many other diseases where 40% or some more percentage, in some 100% people had atherosclerotic cardiovascular disease, in this trial, Vertis 2 CV outcome trial, all of the people, all of the participants had atherosclerotic cardiovascular disease. Now, the the mortality, the endpoint was 11.9% versus 11.9%. So the design of this study was actually to show non-inferiority of ertugliflozin over placebo. So as far as this objective was concerned, it proved that it is non-inferior. But there were some additional benefits as far as secondary outcomes were concerned, and I'm going to show this cardiovascular cause of hospitalization for heart failure. There was some significant improvement. People on ertugliflozin were much less likely to develop those events like hospitalization for heart failure and cardiovascular death as compared to those who were on placebo. I'm going to present these slides very briefly in the next few slides. This is hospitalization for heart failure. This is particularly important because hospitalization for heart failure requires a lot of resources, is not only on the family, the patient, and also the system, and it is expensive. And so if there is any drug which can prevent hospitalization for heart failure, that is, I think, very, very welcome. So in this case, you can see ertugliflozin, 5 milligram, 15 milligram, and this is the combined data. They were much less likely to require hospitalization compared to those who are on placebo. And the p-value is 0.006. So very significant observation. This effect was, of course, expected, and this is a class effect. All SGLT2 inhibitors, they offer this benefit. There was 30%, very, very staggering numbers. 30% less people would require hospitalization if they are on ertugliflozin. Then renal composite, renal death, dialysis, transplant, or doubling of serum creatinine, significantly less people they developed these endpoints if they were on ertugliflozin. Then EGFR, we all consider SGLT2 inhibitors as renoprotective. But actually this concept is somewhat difficult to understand. And if you study the initial fact, like in this one, with 5 milligram and with 15 milligram, there was initial dip in GFR. That is true with all SGLT2 inhibitors. But that does not mean that there is acute kidney injury. That is the effect of contraction of extracellular compartment. So initially there would be decline in GFR, and then it comes up, and then it is maintained at a better level compared to placebo. In placebo, although there is no initial dip because placebo did not have any active salt, but as per natural course of diabetes, and they had further progression of kidney damage, and eGFR progressively declined in 5 years. So I think this is extremely important observation that SGLT2 inhibitors, and in this case ertugliflozin, preserve kidney function. So that is why, according to the guidelines, those who have even slightest manifestation of nephropathy in the form of proteinuria or reduced eGFR, but not to stage 4 and 5, then they should be given ertugliflozin or SGLT2 inhibitors. So this is the summary of this Vertis CV trial. Non-inferior compared to placebo as far as primary composite MACE outcome was concerned, non-fatal MI, non-fatal stroke, or cardiovascular death. But they were better in many other areas, particularly the heart failure, as I have already explained. So let's examine how these findings translate into guidelines. Now this is the guidelines, you're all familiar. This is by the American Diabetes Association and European Association of Study of Diabetes, a consensus statement. They say we start with lifestyle changes and metformin, and then we escalate the dose of metformin. Then we assess these patients and put them into different classes. If they fall in this group, then second line drug would be different, and if they are in this group, then slightly different. But you can see, but the new guideline says that once you have started metformin, you do not need to take it to the maximum dose. You do not need to wait for metformin to fail, unable to achieve the desired A1C to decide about the next line. All of them, they say, before waiting for the drug to fail and irrespective of A1C. That means those who have achieved their goal A1C, even them, if they fall in any of these groups, additional therapies should be given. And you can see SGLT2 inhibitors almost everywhere. This is the atherosclerotic cardiovascular disease patient, either having disease or are at a high risk patient. One preferred agent is GLP-1 receptor agonist, and if patient cannot afford, patient cannot tolerate, then SGLT2 inhibitor for this purpose. Then people with CKD, any degree, or people with heart failure or at a risk of having heart failure, the SGLT2 inhibitors are actually preferred over GLP-1 receptor agonists. And if somebody cannot tolerate SGLT2, then GLP receptors. Here, those patients where there is compelling reason to avoid hypoglycemia and weight gain, and I personally believe that that should be applicable to every person. So we don't want hypoglycemia in every person. So I think practically everybody would be considered for SGLT2 inhibitors. But here I would consider only when that person is unable to achieve their A1C. If somebody has achieved A1C but does not fall in this group, I might wait for the SGLT2 inhibitors. Then there is compelling reason to prevent weight gain. Again, SGLT2 inhibitors are one of the choices. So this is the one where cost is an issue. So SGLT2 inhibitors have already risen from the latest position, because they were the last one to come into the market, but they have risen and taken first or second position. But if you consider European Society of Cardiology recommendation, now imagine they said if you have diabetes with cardiovascular disease, you don't even have to start metformin. You have to start with metformin, maybe if you want to start metformin, but they say in these patients you can start with GLP-1 receptor agonists, SGLT2 inhibitors, again SGLT2 inhibitors in kidney disease and heart failure. In a diabetic patient, you can actually bypass metformin, or you can start these agents with metformin. So this is to highlight that these new drugs, they have taken a very prominent, almost first, if not first, the second position in the algorithms. So if you want to know more about ertugliflozin, it is absorbed. The absorption starts very fast. The peak level is achieved in 1 hour, and the duration, the half-life is 17 hours. So this is unique combination. Very fast absorption and very long action, would work for 24 hours. Bioavailability is 100%. So all of the drug is absorbed from the stomach, and none is metabolized by the liver. All goes to the system, and it is extensively bound to the protein, and that is why it works for such long period. And 50% is excreted by the urine, and slightly less than that is excreted through feces, and some is excreted through other mechanisms. So this is my way of presenting the summary, and I have listed some FAQs, the frequently asked question about ertugliflozin, and after this presentation these are the questions which might come to your mind, and let me give you a brief answer. Is ertugliflozin FDA approved? Does ertugliflozin reduce heart failure? Is ertugliflozin renoprotective? Is ertugliflozin cardiovascular safe? Does ertugliflozin help to reduce weight? Is it true that ertugliflozin does not cause hypoglycemia? Can ertugliflozin be combined with metformin, GLP-1 receptor agonist, and insulin? Does ertugliflozin reduce HbA1c more than sulfonylurea? Does ertugliflozin lowers A1C more than other SGLT2 inhibitors? So these are some of the questions you might be interested to ask, and the answer to all of them is yes. Easy, right? The FAQ exercise continues. Is ertugliflozin FDA approved for heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, or for the treatment of CKD? Other than diabetes, so far, no. But since these are the class facts, I am very hopeful, like other SGLT2 inhibitors, ertugliflozin with the time will also be recommended in this. But till that time, it is not FDA approved for these indications. But of course, many physicians, they use drugs off-label based on their own conviction and their experience. And if you want to use that, of course, that should be considered fair. Thank you very much for watching this video, and I invite you to join my channel called Medurstand. You can scan this QR code or just type Medurstand anywhere on the internet. You will be right into my channel. Thank you very much for watching my videos. Thank you.